I'm going to do my best to talk a little bit about the role of stents. So Darren just did an amazing job talking about the role of angioplasty, which really is more the workhorse for patients with diabetic vascular disease, but certainly stents play a role. These are my disclosures for this talk. So what I'm going to try to do fairly quickly is review the current role for stents and stent grafts in the treatment of advanced limb ischemia, discuss some of the major current limitations with the use of stents, particularly in this population of patients, and then briefly give a little bit of a thought process about some of the things that are coming out that may impact on stent function, but also on the actual use of stents in limb salvage patients. So we're all aware that today we have a lot of options to bring to bear on patients with advanced ischemia in their legs. We have, as we heard from Dr. Legerfo, distal bypass surgery here to the dorsalis pes, which provides an excellent solution for many patients. But there are quite a lot of patients who don't have all the things that are needed to achieve that successfully. And now we have lots of endovascular tools. Our problem in vascular disease today is trying to figure out the right thing for the right patient at the right time that's going to give the clinical result that we want and keep them out of the hospital. And here's the challenges for endovascular treatment in general in advanced limb ischemia. Multilevel disease is common. Long segment disease and chronic occlusions are common. Extensive calcification, at least in my patients, is fairly frequent, particularly to diabetics and those with any kind of renal disease together. And we already heard a couple of points today addressing this. Advanced tissue loss is a different thing from minor tissue loss or rest pain. You need to think about having enough perfusion to support healing of a foot reconstruction, such as a TMA. Large defects in the foot may take weeks or months to heal, and the last thing you want to be doing is wondering about whether your revascularization is still working. Comorbid conditions that are frequent in this population, not only diabetes, but renal disease and malnutrition, can slow the healing of wounds. Ultimately, this is not the heart. They have to actually put weight on this thing, and that's another issue. And concomitant infection. All of these things very frequently mean we have to think carefully about maximizing blood flow, as Dr. Legerfo has mentioned. And it goes without saying that lots of the techniques that we can use today can work in well-selected patients, and we're all trying to avoid these types of things where, placing stents way down below the knee, across the knee joint into a tibial artery, ending up in a below-knee amputation, or taking a patient on the other side who was basically a claudicant with an open popliteal segment and turning them into a limb salvage patient that required a fairly urgent distal bypass when that whole stented segment went down, are not ideal situations. And of course, there are situations like this after surgery as well. So we need to be more thoughtful about applying technologies, including stenting. And particularly, stenting is different from angioplasty because it really can change our surgical options. And I think if it's used in an indiscriminate way, it's probably one of the more dangerous types of things that are being potentially done in the endovascular realm. So this is the task consensus statement, which is now a decade old. And again, the problem with task is it focused everybody on lesion anatomy and made people think about treating lesions. It's really focused on the femoral popliteal segment. This is old data, if you will, but basically it suggested that for minor lesions less than 5 centimeters in length, and these are basically claudicants. Many of these patients probably don't need anything. Endo is a treatment of choice, and then, of course, for more severe lesions, surgery, but there's a lot of people in the middle. But the important thing to remember here is that this really is an endocentric mentality because disease severity in the arteries is the primary driver of endo success. But for bypass, it's really vein quality. And that's not even in the equation or in the document anywhere. But the bigger problem is that most patients with critical limb or advanced limb ischemia is a better term, as I mentioned, have multi-level disease. So this simple scheme has limited relevance, and as everyone has already said in this session, treatment should be limb and patient-specific and not lesion-focused. So if we can just agree on that, we'll actually be way ahead of where much of the world is right now. Also, this is also highlighted by Darren and Joe. The patterns of disease in patients with advanced limb ischemia is a high percentage of patients with multi-level disease and particularly popliteal and tibial disease. And this, unfortunately, makes it a more challenging place, certainly for stenting. Now here's a little math lesson, because people tend to look at lesions and they think about how they're going to get across them. And then there's multiple lesions, but they don't really do the math because, first of all, technical success, which is what they often report, we know is not clinical success. It's necessary but not sufficient. But what you really have to deal with when you're looking at multiple lesions and you're thinking about outcomes is you need to do the multiplication factor here. Somebody says, well, I can cross that SFA lesion, then I can treat that tibial lesion, and this is the data that supports doing this one, and this is the data that supports doing that one. And they talk about things like target lesion revascularization. Well, let's say you've got an SFA occlusion and a tibial occlusion, and the probability of success for the SFA is 0.7, and for the tibial, if you can believe it from certain papers, 0.6. Well, actually, for the limb as a whole, that's going to be 0.42 by my math. That's not such great odds. So I think, this is reality. I mean, each of these, if you have a lesion-centric mentality and you focus on much of the data that's lesion-based, you need to at least add things up and consider the overall strategy. And as Darren just pointed out, the success of the first treatment does matter, particularly for patients with diabetes and critical limb ischemia. And this is the problem for stenting. It can work in well-selected patients, but we still have not conquered this problem. Restenosis is frequent. The new technologies are improving, but our strategies for treating it are still not that great. We'll talk a little bit about that. And without a doubt, restenosis in the periphery remains the single greatest unmet scientific problem we have in our vascular patient population. Here's a look at stents versus plain old balloon angioplasty. I think for the most part this debate is gotten a little more limited based on a number of trials looking at stenting in the SFA. But I want to point out that although in all of these trials, stenting had a better result than plain old balloon angioplasty by different degrees, the lesion lengths involved in these trials in the SFA are very limited. So if you look here, these are mostly, really actually, task A lesions. Just a couple at 10 and 12 centimeters long that are actually task B lesions. And actually the proportion that have occlusions for most of the trials, with one exception, relatively low. So these are not the patients that we're treating in this room, in this conference. But this is the data that people run around talking about. And if you actually look at the data, it looks pretty good. Stenting is better than angioplasty in the SFA for focal to mid-length lesions. But as you get into longer lesions, it gets a little less clear. The differences are not as great, although the newer stents do appear to be heading in that direction. Now here's a more typical patient that we would see with advanced limb ischemia, and this is a patient with, you can see a relatively long segment of SFA disease, including a segment that's completely occluded and a longer segment that's fairly diseased. It reconstitutes, pretty much at the above knee popliteal. You can get across this, as you can see in the slide, and you can stent it. But what can you expect for an outcome? That's the question. So this is actually data from the group at UC Davis, John Laird. They're fairly aggressive and skilled endovascular therapists, and they're looking in today, 2014, with the tools that we're currently using, what's the outcome for stenting and angioplasty for long lesions in the femoral popliteal artery, and clearly balloon angioplasty doesn't work that well. But even if you look at stenting, and this is just at 1 year, and admittedly the numbers are fairly small, it's only 50%. When you're looking at lesions that are 15 centimeters long. Now, in a limb salvage patient, this is actually not the exception. This is common. And as the lesions get longer, the results get worse. Now, we do have drug-eluting stents now. We have one drug-eluting stent approved for the lower extremity. It's a silver paclitaxel eluting stent from Cook. And the data that supports that marketability of that stent is shown on this slide. It's a trial that compared drug-eluting stenting initially versus angioplasty, and then there was a group that had provisional stenting. And the drug-eluting stent in this trial had good performance and was statistically superior to angioplasty, and also was superior in the provisional arm. However, if you look at the results of the trial in comparison to other stents, first to note again that all of the trials, look at the lesion lengths that were on average being treated. They're very modest. So these were well-selected patients. They supported the safety and relative efficacy of the treatment, but they're actually not that much dramatically better than other nitinol stents that are out there. And again, most of the data here is related to relatively short lesions. Certainly, it is impressive when you look now at the 3-year data that it does seem to be holding up the difference in the silver PTX. But the problem we have is putting this into the context of the lesions that were treated and also other currently available nitinol stents. So I think, yes, for longer lesions, if you're going to do stenting in the SFA, it's probably better than angioplasty, but the role of the drug coating is still a little bit unclear. I will point out that this data is in the context of what we know, which is that restenosis rates, at least in human beings, still continue to increase beyond 6 and 12 months. And most of the data that's been published is 1-year data. So I think having 2 and 3-year data is really important for us to see the value of these tools. And here again, for long SFA lesions, it looks like, this is not randomized data, this is just data from the literature. If you compare the Zilver PTX to some of the other currently available nitinol stents, it looks like the trend is a little bit better. But again, remember that these are modest lesions. Even these so-called long lesions in this study were not as long as the lesions treated in the paper by Laird. So still a little bit unclear in long SFA lesions whether stenting has a huge value, particularly in critical limb ischemia, and whether or not the drug-eluting stent is better. But there seems like there's a sign that it might be. So why is in-stent restenosis an issue? It's an issue because even today, despite using a myriad of tools to try to treat it, the results are still very challenging. This is also, again, from John Laird's group at Davis, looking at a recent group of patients they treated for in-stent restenosis in the SFA, which is about 30 to 40% of the patients that they had treated during a relatively a time span. And they grouped them by lesion length, short stenoses, which are less than 5 centimeters, type 1, longer stenoses, and then occlusions. And you can see here that the results for all of them are actually not that great. At just 1 year of follow-up, the failure again rate is pretty high, but particularly for groups 2 and 3, the failure rate, and this is using a myriad of techniques that you see on this slide: atherectomy, cutting balloons, lasers, cryoplasty, a variety of tools that were used. No matter what has been brought to this problem, the results are fairly recalcitrant. So this is a big problem for us. We would rather not have it happen at all, and maybe drug elution will be the key. What about covered stents? There's some data out there that suggests that covered stents may be beneficial for longer lesions and possibly even for in-stent restenosis. We looked at this a while back at our San Francisco cohort, which is a mixed cohort of patients that had critical limb ischemia, but mostly claudicants. And we found that overall these were actually more longer lesions, a little bit more challenging certainly than the patients in the IDE trials I just showed you. Overall, the results were not bad, but about 40%, 43% of patients required another procedure within a year. And of those, about half of them had a relatively significant reintervention because they failed in a major way. They either required a bypass or they required thrombolysis and prolonged hospitalization with some fairly significant costs associated with that. So the issue here was that some of these patients required smaller diameter conduits that were used. Certainly the TASC-D, more extensive lesions, was a factor. And then the use of dual antiplatelet therapy, which should probably be standard, was not present universally in all patients. So all of those factors, including, in particular also, the coverage of distal collateral vessels, was found to be associated with fairly adverse types of reinterventions. So we learned a little bit from this, and that these are factors that are less favorable. But I think when we look also at a contemporaneous series, here extending a little longer in time, actually comparing to plain old bare metal stents, we do see that the covered stent performs better in terms of freedom from reintervention, if you can see on the left-hand slide, for extensive SFA disease. But what's a little bit bothersome on the right-hand side is that it's only the patients who had failed stent grafts represented with acute limb ischemia. And that's particularly daunting if the patient started out with claudication. You know, it's only, you might say, only 12% of patients, but that's a pretty big number because that's beyond their natural history, for sure. So you have to be careful. So what about stents in the tibials? And here we have growing amounts of, but still very modest data. Certainly there are reports out there. They're mostly single-center reports, retrospective, with very modest follow-up time. And they suggest that localized tibial stenting compared to balloon angioplasty may be similar. In some cases, there may be some areas where there might be a suggestion that they have a better result than angioplasty, but really there's not very good data there. And we are starting to see some interest in drug elution in the tibials, but still very, very modest reports. This is one randomized trial, the Destiny trial, that showed that an everolimus-eluting stent versus a bare metal stent in a tibial artery seemed to perform better in terms of patency, but I will point out here that the lesions are 2 centimeters long or less. These are very, very focal lesions. I don't treat we don't see a ton of those patients. Certainly there are some, and I think it's going to be hard to ferret out what the role of these devices are in the larger group of patients with advanced limb ischemia that we're talking about at this meeting. So what's coming or what's evolving? I think one of the major issues with stents in lower extremity arteries particularly is the distal SFA, and the popliteal segment is a very vulnerable segment. It's really not a friendly place for a stent. The helical woven stents are more flexible and may have a better result than certainly some of the other stents that we're using, but there's really not enough data yet to say for sure. Drug-eluting stents we talked about. I think bioresorbable stents are actually a pretty exciting idea. If you could achieve the scaffold that you need and then ultimately have the implant go away and leave the patient with just their native artery, to me that's an ideal solution, but we're still a ways from having that be reality. And then finally, what will be the impact of drug-coated balloons? This could be a game changer, really, in the use of stents in the lower extremity, because it looks like, at least in the SFA, there's some early data that suggests that drug-coated balloons may have a better outcome than certainly plain old balloon angioplasty. And I think we're in the midst of a whole series of studies that are going to ferret this out over the next couple of years as to what the role of drug-coated balloons are. But certainly if you could avoid putting a stent in, and if you could avoid that problem of in-stent restenosis, that would be a huge advantage. There's been one randomized trial reported, this is from a single center in Italy, in below-the-knee vessels that suggested that drug-coated balloons were better than plain old balloon angioplasty. However, a larger study that has been done that has not fully reported, the Medtronic Impact Deep study, basically reported that their data was negative. We're still waiting to see an actual publication from that study, but they pulled the device from the market. There's another large study going on in the below-the-knee disease with the Levant version of the barred version of the drug-coated balloon, and there's 2 SFA trials that are still waiting to report. So there's going to be a lot of data coming out about drug-coated balloons, and I think, as Darren pointed out, balloon angioplasty probably still is the workhorse below the knee for endovascular. If we can get results that extend the durability of balloon angioplasty, that would be great. But some of the challenges that have arisen with this data are actually related to things like embolization of the drug and inflammatory reactions in the foot. And so I don't know that we're quite there yet, but I think this is an area that we have to monitor very closely. So to summarize, what are the current, in my opinion, uses of stents in the treatment of critical limb ischemia? I think for the treatment of SFA disease, and it's rare to have isolated SFA disease, but you can have it, that is probably better than plain old balloon angioplasty for most lesions. I'm not still sure myself when to use the drug-eluting stent. It may be better for longer lesions, but I'm not sure we need it for every case. More data is needed. Covered stents, I think, are probably going to be a niche area. I think their role is not really clear. Their midterm patency may be better for longer lesions, but the sequelae of failure are a bit worse and costlier, at least in our experience. The popliteal artery is a relatively unfriendly place to put a stent. We try to avoid it as much as possible. The newer helical stents offer promise, but I think we need more data. And for tibials, I think right now the answer is really just occasional spot use for bailouts or dissections. Really try to avoid the use of stents below the knee because it can compromise surgical targets. Drug-coated balloons, if they're successful, I think could alter the endo paradigm altogether away from stenting, and that, to me, that would be a gain. And hopefully stents in the future will eventually go away.